Dr. Bucshon for 5 minutes of questioning.
Thank you. First of all, I want to associate myself with the comments of Dr. Ruiz. I couldn't agree more, and we have bipartisan legislation we're working on to solve some of those challenges. I do want to thank the full committee chair, Ms. Rogers, and subcommittee chair Griffith for scheduling what I consider a critical hearing for the future of healthcare in the United States. I know that sounds a little big, but I'm telling you, this is a big problem we have to address. The entire premise of MACRA, of course, which was passed in law in 2015, was to move us away from the old model for reimbursement of physicians that was driven by volume, transition us to a system where providers were reimbursed based on their ability to deliver high quality care. Why was this important? In fee-for-service model, the best provider is reimbursed at the same level as a provider that may be providing less quality care. I've never thought that was right. It also leaves volume as the only dial a provider can turn to impact reimbursement. Unfortunately, as is all too common in DC, in my opinion, the executive branch under both political parties has failed to fully implement the law in an adequate fashion. And in some cases, not even bothered to really try and implement the law, like ignoring PTAC, for example, as was mentioned. I mean, there are massive problems that we see in the MIPS program and the alternative payment models, primarily that these programs are somewhat overly bureaucratic and make it difficult for smaller practices, particularly in independent or rural practices, to participate, as has been mentioned. This is not my opinion, by the way, as was mentioned. 2 GAO reports have said this. Dr. McWilliams, the MIPS program is budget neutral, correct? What I mean by that is whoever gets bonuses, you have to have people getting cuts, right?
That's my understanding.
Right, and I don't think that half the providers in America are providing poor quality care, but essentially it's a budget neutral program. Everybody that goes positive, you have to have just as many negative. That was a fundamental flaw at the time, but I couldn't do anything about it. I tried. These factors and other reimbursement inequities, as was mentioned by Dr. Ruiz, like a lack of inflationary update for physician reimbursement, is just devastating, not even keeping up with practice costs. In addition, I just want to say this, it's helped lead to the morale amongst providers being extremely low. That's not my opinion. I talked to doctors who I've known for decades. And the burnout is high, and we're losing quality people, particularly in rural America. I was a practicing heart surgeon for over 15 years, served as president of my medical group, and I can tell you from firsthand experience, the lack of proper reimbursements for physicians will ultimately result in our constituents having access challenges to quality, affordable health care, regardless of where you live. I agree with Dr. Ruiz. My issue, everybody should have access to quality, affordable health care. Reimbursement is a substantial challenge. So unfortunately, while we repealed the sustainable growth rate formula, many physicians continue to experience steep cuts, and the legislation that was previously mentioned would help mitigate some of that. Everybody else in the healthcare system gets these updates. I don't know if people know that. Physicians don't, hospitals do, others do. They get updates based on inflation. So we have to fix that. I want to touch on a different subject though. Dr. D'Agostani, my specialty, cardiothoracic surgery, and others, such as neurosurgery and orthopedic surgery, have established clinical data outcome registries, the STS database, for 30 years. Valuable tools to support performance assessment and value-based care models. Unfortunately, these registries cannot realize their full power without better access to Medicare cost data. In the 117th Congress, I introduced Meaningful Access to Federal Health Plan Claims Data Act to help remedy this situation and make access to Medicare claims data more readily available. Furthermore, CMS has failed to take advantage of these data registries, in my opinion, and the Qualified Clinical Data Registries reporting program needs an overhaul. Do you believe that CMS needs to reimagine how it supports physician-led clinical data registries, including improving access to cost data?
Yeah, I think data is not only important, it's critical. None of us can survive in an ACO world if we don't have access to timely and accurate data. You're taking a risk at a time where physician reimbursement is down, physician morale is down, number of physicians going into medical school is flattened, especially for primary care and some medical subspecialties. So I think it's critical to work with CMS and CMMI on having meaningful access to data and be a stakeholder and be at the table. Groups like APG could provide a lot of insight we're working as well as group with our members of 360 plus group to organize our data and to be able to share that data and publish study. Because without that knowledge, without knowing what works and what doesn't work, we're not going to be able to prove and refine those models.
Thank you, Mr. Chairman, I yield back.